Lab calling. I have a critical on your patient. Think quick. Who's your normal patient with potassium above 6? Patients in kidney failure, patients that have missed dialysis, that's a pretty easy answer. You usually get rid of, filter out the potassium through your kidney, so if they're not working, it's going to build up. DKA is a little more complicated. We have to remember that potassium typically lives inside the cell, and insulin is something that helps keep it there. When you are in DKA, you don't have enough insulin, and it allows the potassium to shift outside of the cell and into the bloodstream. And this can just be coupled on top of your patient going into acidosis, which will mess with the hydrogen ions, but I digress. Another big cause is cell destruction. Remember, I said potassium lives inside the cell. So if those cells burst, that potassium has to go somewhere and it heads into the bloodstream. That can be seen with crush injuries, burns. And then additionally, you can look at meds. So you're looking at potassium-sparing diuretics. That's not Lasix. Remember, Lasix gets rid of potassium. But potassium-sparing diuretics like spironolactone. Additionally, meds like ACE inhibitors, ARBs, and even patients overdoing potassium supplements. You're going to want to put this patient on tele. And why do we say that? Because potassium can kill you before you have any symptoms of it. When potassium is high, the heart cells are harder to reset between beats. So in the beginning, you are going to see, they say tall tented T's for high potassium, but you also might see prolonged PR. Then as the potassium increases, you're going to start seeing a wider QRS. You might see a heart block or bradycardia, and eventually that's going to lead to either VTAC, VFib, PEA, or even asystole. Sometimes the first order you see on these patients is calcium gluconate, and you're like, what the heck? This is not going to fix your patient's potassium at all. It's going to stabilize your patient's heart while we fix it with the other meds ordered. Usually it's given first. Things we need to watch out for when we give calcium gluconate is, one, it's a vesicant. It's going to irritate your veins. Make sure you have a good working IV. Second, you need to monitor your patient's blood pressure during administration. The next order is for IV insulin and dextrose. The dextrose is to counteract the glycemic lowering effects of the insulin, but ultimately the goal of the insulin is to help push the potassium out of the bloodstream and back into the cell. The only insulin that should be given IV is regular insulin. So you are giving IV push regular insulin with IV push dextrose. Now remember, dextrose is very, very viscous. It's thick and it takes a while to push. Personally, I give the dextrose first because if the line blows, I don't have to worry that my patient has not had enough sugar. Albuterol is another med that can shift the potassium back into the cell. It needs to be used cautiously if your patient's already tachycardic or has cardiac issues going on, as it can make those issues worse. Back when I first started nursing, we used to see K-oxalate a lot, and we'd make the patients poop out the potassium. It's like legit, like go lightly. They get rid of the potassium. We have Lokelma now, which is so much better. It's a powder. It's mixed with water. The big thing with Lokelma is you're supposed to wait 2 hours before and after other medications to give it, which sometimes when your patient's potassium is critically high, it's hard to administer it safely. Lokelma is actually a potassium binder. Binding is a way you can get rid of potassium, like actually flush it out instead of just pushing it back in the cell. Hope this helps make it make sense.